Okay, so one of the things we're going to talk about this morning, and we'll kind of go ahead and record this, it might be worthwhile, is the use of various drugs during the preoperative and postoperative period and intraoperative period to protect our patients and give them a high quality and safe and comfortable anesthesia. Okay. Now, anesthetics around the world and for the past 100 years have been founded upon a combination of drugs, usually including two primary groups of drugs, and they are the gas anesthetics, starting back as far as the first gas anesthetic, ether, up through things like halothane and enflurane and isoflurane and sevoflurane, the other gas anesthetics, and narcotics. Pain relievers like morphine and Demerol and Dilaudid and other narcotic pain relievers. So around the country today, around the world today, many people, I would say most people who have abdominal surgery are going to be breathing in a gas anesthetic and receiving narcotics for pain relief. And both of those drugs are great choices. They happen to now be available in generic form, so they're dirt cheap and they're very effective, but both have two dangerous and annoying side effects. The gas anesthetics are wonderful, but about a third of people who breathe the gas anesthetic will wake up with severe nausea and vomiting, or post-operative nausea and vomiting, which can be very, very, very difficult emotionally to deal with and can cause a lot of pain and discomfort. 30% plus. The other issue that's more dangerous about gas anesthetics is that the gas anesthetics are lipophilic, or chemicals that tend to dissolve in fat. And as you know from mixing up Italian salad dressing, oil and water don't mix. So that when we breathe gas anesthetics, a significant portion has the potential to dissolve into the fat. When that happens, and you wake the patient up later in the case, you may have some gas anesthetic sequestered in the fat, and then that can come creeping back into the bloodstream. So what can happen is you can have a patient who has their anesthesia turned off, they wake up, and then surprisingly they may be put back to sleep by the anesthesia creeping back out of the fat into the bloodstream. So they can inappropriately and unexpectedly have a drop in their breathing in the recovery room or later because the gas anesthetic sneaks back out of the fat. In that case, if you have an obese patient with already impaired lung disease, if they already have sleep apnea, if they have operation on their abdomen and they have some pain and they get some pain relievers and some gas anesthetic, you can turn a recovery from a normal process into a potentially devastating event where you decrease breathing, low oxygen, you may even have cardiac arrest and death. So the gas anesthetics are good, but they have two risks. One, nausea and vomiting, and the other is unexpected respiratory depression. To protect against the problems with gas anesthetics, our anesthesia uses intravenous anesthesia called TIVA for total intravenous anesthesia and no gas. That's good. The other chemical, as we talked about, that we commonly use for surgery is medicines that are called narcotics. And narcotics are wonderful pain relievers, but again, two problems. One, narcotics can cause, just like the gases, nausea and vomiting. So oftentimes if you have a lot of pain and you get a lot of pain medicine, all of a sudden you can find suddenly the patient is nauseated and retching. So Joe is giving somebody pain medicine in the ER for their kidney stone. They give them a dose, and all of a sudden he comes in and they're throwing up. Because the dose of narcotics, as it gets higher to relieve pain, results in nausea and vomiting. If you also have nausea and vomiting from the gas anesthetic, that's a really unpleasant, really difficult problem. But just like the gas anesthetics, the real dangerous problem of narcotics is that they are respiratory depressants. So that when you give patients narcotics to relieve pain, you have the risk that you'll depress their breathing. And if you depress their breathing and they're also obese, if they've also had major abdominal surgery, which interferes with breathing, if they also have pain and you're giving them more narcotics, all of a sudden you've got a potentially dangerous situation. And there, narcotics plus gas can lead to respiratory compromise, low oxygen, irregular heartbeat, and occasionally death. So that's the background of our desire to use opioid-sparing anesthesia. That is, drugs that give us the same value to our patients, where you don't have pain and discomfort, but you don't have the complications of the narcotics. And there's a whole area of research where we use a variety of drugs to avoid the need for rescue narcotics. And so a list of the drugs that we use are drugs that affect two receptors in the brain. One is the alpha-2 receptor, where clonidine works in the brain, and the other is the N-methyl D-aspartate receptor, or abbreviated the NMDA receptor, which happens to be where ketamine works in the brain. And so we use as a combination low-dose ketamine, a new drug called dexmedetomidine, and melatonin. And these drugs in combination have decreased our pain in our patients and our need for narcotics by over 95%. So in our patients, we use no gas anesthesia, and we use very little narcotics, so our patients have very little nausea and vomiting. You met all these people from last week. Does anybody have a difficult anesthesia that they were complaining of, or nausea or vomiting or problems like that? No. No one complained of any pain. They had a little bit of pain. They barely even took a Tylenol for it. So that's a demonstration that we use a technique to protect our patients from pain, but also protect them from nausea and vomiting and respiratory depression by using what's called opioid-sparing anesthesia. And one of the neat new things is that melatonin, over-the-counter melatonin, is an opioid-sparing drug.
So the book doesn't say to take melatonin in the morning for surgery. It says the night before, right?
You take them the night before, and you're going to get one from us here.
Oh.
So take one the night before.
Have you been taking it?
Good.
It's okay?
Yeah. Stop taking it and restart.
Okay.
Stop it now and restart it tonight.
You can't get too much of it.
Right. There's no upper.
Would I stop my Toprol the next morning, though, after the surgery, until we discuss what my blood pressure is?
You and I are going to talk every day. Don't take any medicine at all without talking to me.
I guess my only other question was, I've had a CAT scan lately, and they mentioned that I have certain areas of calcification within some in my kidneys and other places. I know that the cholesterol problem goes away with the surgery. Will the calcification eventually dissolve and go away, or is it always going to be there?
That's tough. Once you've turned a piece of your body to stone, it's tough to get it back out. Now, we know that the cholesterol plaque can go down with the low cholesterol we get and the low triglycerides, but getting stone out of your body is tough.
Are you frozen?
No?
Okay, so it's me. Sorry, I just wanted to.
Good. You want to say hi to everybody?
Me?
Yeah, me?
I'm Dixie, and
Who's here with you?
this is my husband, Tony.
Where are you guys from?
We're from Spokane, Washington.
Good. How'd you find out about us?
I have a friend, Dave Hannett.
Oh, yeah, of course.
Yes. And I've been researching you for quite a while on the internet. And I just feel like I've come to a crossroads. I need to have either double knee replacement,
Ouch.
or I need to get the weight off.
Well, let me just tell you. Pain from double knee replacement, pain from the MGB.
Yes. Yeah.
We've had people that have both, and they
Yeah.
call me and they say, this is no MGB.
Yeah.
They call about the double knee replacement. You have to be quite a tough individual.
Yeah.
That's real pain.
Yeah. it
MGB,
is.
they barely took a Tylenol.
Yes.
Yeah.
And, I realize this isn't going to cure my arthritis, but I think I can at least extend the life and hopefully maybe be able to exercise and strengthen the muscles and stuff.
Well, we would appreciate you giving me follow-up on that question. We have had a lot of people who were told prior to surgery they need a knee replacement or two, and after surgery their orthopedic surgeon has said, no, you don't need a knee replacement. So we'd like to hear from you if that changes.
My knees are obviously, when you look at them, they're destroyed in there. But I think if I can get the weight off and can exercise, and build these muscles, and not have the constant pain, I'm really looking forward to that. I've read a lot about that, so I hope I'm not hoping for too much. But the other thing is also at that crossroad is my dad is an adult onset diabetic.
Right.
And my mother died of congestive heart failure. And it's just
You don't want either one
preemptive
of those.
strike for me.
Questions that you guys have for me? Anything you said? Did you guys fly or drive?
We flew.
When you're flying down here, say, when I see that character Rutledge, I want to ask him a question.
Actually, my biggest question is when I can take a shower, 'Cause
That's actually-
my hair is very important to me.
That's a good question. It's actually in the manual. You can take it the next day.
Oh, it is the
Yeah.
next day. I
Yeah, a
missed
lot of
that.
people focus on the manual because we ask questions and things like that ahead of time, but the post-operative stuff, there's 15 pages of discharge instructions and things like that, like when you can take off your stockings and what you can eat, all that's in the manual, and you'll get another copy of the discharge instructions from Trish or Sandy post-op, but basically they're all in the manual.
No, I've read all the forums, and I don't have any pressing questions. I'm ready to make a change.
Good. Well, welcome. We're happy to have you from so far away.
Thank you.
Joe, how is a knee replacement?
They're uncomfortable yet. I had to take a couple Percocets to make it through the week. But, I work 12-hour days, about 4 or 5 days a week with them. So I'm glad I have.
Right.
But I'd like to try to avoid getting both the hips done before I'm 65,
Yeah.
because they're totally toast now. But I'm ready for this. I've been ready for about 6 months. Change the way, the importance of food, and whenever they say, oh, you won't be able to do it, you love food too much. I don't even like food. I mean, there's certain foods I enjoy, but I'm done. 4 nights in a row I come home from work, I haven't eaten dinner, and not hungry. So mentally, I'm getting the mental part, but I need the help, because if I get hungry, I don't stop.
Right, that's
If I need to eat, I just eat. I think the thing I'm most worried about is this neuropathy and arthritic pain, because I've gone 12 days now without my Celebrex, and I'm about ready to shoot myself. People at work go, what's wrong with you? Nothing. I'm just uncomfortable. I spent yesterday with 12 hours with the 10 unit frying the heck out of me. But, it is what it is. I'd rather do this I'd rather be thinner and have the pain than be fat and have the pills. I mean, it's that simple. If I can get off all the pills, it's, diabetic medicines and sleep apnea machine and those things, and I still have neuropathy, then I'll take Neurontin and Tylenol once in a while and live with it. But I can't have Celebrex again, I won't. But, I've had it for a couple periods of time where I haven't had it. It's uncomfortable not having it. Once you've been used to having some,
We expect to be off the Celebrex and feeling better post-op. That's our hope and prayers.
And I have no joint spaces left on most of my joints, and that's done in my feet. So when you try to walk, it's like you fracture your feet all over every time you take a step. So, but again, I've had multiple friends here at the hospital have had it, except for one person who didn't have the hopeful expected outcome that he was hoping for. Every single other person's walking around just like our friends here said, like Energizer Bunnies, little pink bunny. It's like somebody stuck batteries in them because they just can't stop. And even when they talk to you, you want to smack them. Shut up. You're just so happy that they're big. And they're not big. I mean, my friend Louis is still a man. He's not a stick. But he's 185 or 90 pounds now, and he's a man, he looks great.
Have you ever seen him like a month?
I saw him the other day.
Tomorrow.
Tomorrow, he wants to watch.
But it's like, it's like the life change, you're getting born again, so try to, deal with little tiny spoons and little shot glasses of water, Gatorade. And I'm glad Gatorade, I'm in heaven, man.
We've got the
I lived on
Gatorade.
that for 4 years playing football. But since I've been diabetic, I can't drink it at all, so now I'll be.
Yeah, we hope we're gonna change that.
Mr. Stokely and I will be buddies.
You'll like it, it's just as nasty as it was when you played football.
Are there any questions you guys we should go over? Or?
That's not for me, Diane might have some.
I don't think so. I've been reading the book and reading the book and reading the book and reading the book and reading the book. So making my own little charts of what happens when.
We actually took the book apart a little bit, tried to make it more user-friendly for us, because so you have a better idea of diet. Because that seems to be like, you look at it and you go, just what do I eat? Or when do I eat it? So once you put it all together, it's really not so bad. I made myself a little calendar, July 2nd, first real meal. But, where I can just eat whatever I want that my body will tolerate.
Most good food.
No, it's not so much that, it's just that it won't be as restricted, because by restriction, if you go 7 to 14 days, and then 14 to 28 days, by the time you get to that July 2nd date, you've done the exact things that Dr. Rutledge says is the best way to get started. And you've conditioned your new surgery sites to tolerate being a human being again. And from what everybody else says, they enjoy fish, and chicken,